Good morning. My name is Zohaib Bakr. I'm an internal medicine PGY1 resident at Ascension St. John Hospital. I would like to present my poster, which is about a rare case of a loculated pleural effusion that is caused by chronic pancreatitis. So, generally, when we see large unilateral pleural effusions, we tend to think of more common causes such as infections and malignancies, but it's important to keep in mind about the rarer differentials as well, such as pancreatitis or even chronic bowel halves, especially in the setting of a patient with a history of chronic alcohol abuse. So that brings me to my case, which involves a 65-year-old male with a history of alcohol abuse and retroperitoneal fluid collections that was diagnosed a few months prior to his current presentation. So now he came in with left-sided chest pain of 2 weeks duration that is constantly present and not aggravated by exertion. He denied any shortness of breath, lightheadedness, fever, cough, abdominal pain, vomiting, or diarrhea. On physical exam, he was hemodynamically stable, afebrile, and maintaining saturation on room air. Auscultation of his lung fields revealed decreased breath sounds on the left lung base, but the rest of his exam was unremarkable. We got a chest x-ray which showed a large left-side pleural effusion, and his initial labs were unremarkable except for a mild leukocytosis of about 12,000. But along with a heart rate in the 90s, he had 2 out of 4 SIRS criteria positive, due to which we started him on broad-spectrum antibiotics, and had blood cultures drawn which did not show any growth. So we did a thoracentesis, and about 1.3 liters of fluid is aspirated and sent for analysis, which fit Light's criteria for exudative fluid, as it had elevated LDH and protein levels, but interestingly also showed highly elevated amylase levels. So this raised a suspicion that pancreatitis could be the cause of the pleural effusion. A serum lipase was sent and was mildly elevated, and a CT thorax and abdomen revealed fluid collections near the tail of the pancreas and also the left kidney, which was possibly representing cirrhosis. An EGD with ultrasound which was done which showed a normal pancreatic duct, but no pseudocyst was identified. There was free fluid around the tail of pancreas, suggestive of acute pancreatitis of the tail. There was no intervention done. The patient was treated conservatively and discharged. But since then, he's had 2 readmissions for recurrent pleural effusions and retroperitoneal fluid collections. He had a repeat EGD with EUS, and a pseudocyst was identified, which was drained, and he was asked to follow up in 2 weeks. So that's my case, and some of the main points of discussion that I would like to have include the etiology of these massive pleural effusions that are caused by pancreatitis. In this case, it is likely due to the presence of a pancreatopleural fistula, which is known to have a very low incidence rate of just 0.4%. So these fistulas are thought to develop from ruptures of pseudocysts into the retroperitoneal space, which is likely what happened in our case as well, but it could also happen in the setting of trauma. There are various diagnostic modalities for pancreatopleural fistula, which include pleural fluid amylase levels, which do not really have a particular cutoff, and also not very sensitive, but other imaging modalities include CT, MRCP, ERCP, and fistulogram. So with the current literature, MRCP seems to be more sensitive in delineating the fistula tract. An ERCP or EGD with US can also be done, which is invasive and is usually the test of choice when endoscopic intervention is anticipated. A fistulogram is generally used if the MRCP and ERCP are inconclusive. When it comes to management, it is still pretty debatable and disputable, as not enough research is available to guide whether surgical or endoscopic intervention is more beneficial than just medical therapy alone, and if so, whether the timing of these interventions can help change the outcome. So, as seen in our patient, the diagnosis was delayed, resulting in an increased length of stay. He also failed medical therapy with recurrence and multiple readmissions and may have benefited from earlier intervention. So, goals of my presentation are to raise the awareness of these etiologies and to have a higher index of suspicion that can lead to early diagnosis, and also to encourage research to develop better guidelines that can help in the management of pancreatopleural fistulas leading to massive pleural effusions. So that brings my presentation to a conclusion. I would like to thank you for your time and also for giving me the opportunity to present this poster. Thank you.